clearly COVID has been almost a ubiquitous part of 2020 with very significant impacts. Let me highlight two very different things that I was involved with. The first was a deeper dive in terms of the experiences with patients with MPNs. And interacting with colleagues from around the world, we created an international MPN patient survey and had data from over 1,500 patients with MPNs. And there were some notable findings. First, relatively low numbers of MPN patients that had been diagnosed with COVID. Now, this was concluded this summer. There undoubtedly have been more since, but not suggesting any overrepresentation of MPN patients obtaining COVID. Second, we saw that without question, the advent of telemedicine has rapidly impacted the care of MPN patients, with, I'd say, almost the bulk of MPN care rapidly transitioning to being telemedicine visits. That has both some pluses in terms of lack of travel and ease of access for individuals, but also some negatives that some patients have felt a further lack of connection with their healthcare team, lack of ability to monitor spleen size or other physical exam findings. We did see some impact on symptoms, and particularly anxiety, distress, and many other factors that have been very relevant during the time of COVID that have really impacted these patients. We look forward to following up with this group and subsequent studies as we delve a little deeper into MPN patients that have had COVID itself. Now, although I'm not one of the co-authors, it's worth mentioning the important work by our colleagues in Italy that had reported in leukemia earlier this fall, I think fairly recently, that they observed that patients who rapidly discontinued ruxolitinib after being infected with COVID as having very poor outcomes. There's been concern that by pulling away that cytokine inhibition that occurs with the JAK inhibitor, that patients can have worse outcomes. So that's something in the COVID guidelines that colleagues and I have put forward through ASH on the ASH website to not abruptly stop ruxolitinib in individuals that are being treated. Now, the second abstract I would highlight, our center has had the honor of being involved with a spontaneous but very effective consortium of many cancer centers, both in the US and across the world, known as the CCC19 Consortium. And we presented, a subgroup of us working in heme malignancies, an abstract for this year's meeting that showed that looking at patients with heme malignancies overall, the outcomes for those that had the COVID infection were poor, with 37% developing severe COVID-19 and a mortality rate of 17%. The patients receiving recent cytotoxic therapy seem to have the particularly worst outcomes compared to those treated with really more in this survivorship category. We are actively looking at subset analysis and trying to delve into deeper issues regarding individual diseases, such as MPNs versus myeloma versus lymphoma. Obviously, patients with heme malignancies have some very different treatment arcs and different therapies that they are being exposed to. But a lot more for us to come as we clearly learn about the significant impact that this virus has had on both afflicted patients and survivors.